Hi and welcome everyone. Thank you for joining this session on researching beyond the binary, LGBTQIA plus health. I'm Matthew Shays, one of your university librarians, particularly as you can see, I'm the San Marcos campus librarian. So for those of you who are from San Marcos, hi. But otherwise, you may see me more with interlibrary loan requests and on the chat, like our Ask a Librarian chat service online. Stuff like that. So you might encounter me from there too. My pronouns are he, him, his. The intention for this session really is to introduce the university community, students, faculty, staff even, with skills and knowledge and resources to support evidence-based practice and research for LGBTQIA plus populations. While there have been increasing attention and discussion about the health outcomes of LGBTQIA plus populations, what we're going to be really addressing is how there is still a great deal of work to address the inequities and the gaps in the care of patients from those communities. And whether we are consciously acknowledging it or not, we have a significant responsibility in developing ourselves as researchers and practitioners, so we're not reproducing these issues and instead working to address them. Before I get into the heart of the session, I do want to stress that I do not personally have a position within the LGBTQIA plus communities. Full disclosure is that I'm a white, straight, cisgender male, so I have several privileged social statuses that have shaped my life experiences. So I'm by no means an expert on LGBTQIA plus issues, but these are incredibly crucial topics for us to work on collaboratively. So please feel free at any time during the session to ask questions, bring up strategies of your own, other approaches and perspectives that we should all consider, including myself. And for the purpose of this session in particular, because there is a lot to tackle when it comes to research and clinical practice when it comes to LGBTQIA plus communities, what we're going to do for this workshop, especially since we only have like about an hour, is to look primarily at navigating the scholarly literature, how it informs our research and clinical practices, and hopefully connecting it all back to the issues of equity, inclusion, and justice, especially as they relate to LGBTQIA plus communities. But as we'll talk actually more is that it actually can extend beyond those communities, and particularly talking about those communities as it relates to other social issues, as it relates to race, or as it relates to like class, where you live in particular. All those type of inequities can intersect, and we're actually going to get into that in a little bit. But yeah. So before I go into the actual strategies and resources that I have prepared for all of you, I do want to address what exactly is gender and what exactly is sex and sexuality. Because a lot of times there are a lot of different conceptions, and what we're going to talk about too is there's a good reason for that, about what those represent, what they mean to us, and how we express them, and everything in between. So for my next part here is, well, first I'm going to address, why this actually matters in the first place, in terms of why are we discussing health research and evidence-based practice when it comes to LGBTQI plus communities, because really the idea behind evidence-based practice is that we're being informed by the literature to provide the best practice, right? Or at least to inform us towards the best possible extent of our practice. But as I was kind of alluding to before, is that with the LGBTQI plus communities, even though we are talking more about them in terms of health and clinical care and so on, there's a lot to be left desired, especially for the health outcomes and just patient care outcomes for these communities. In particular, as you can see here, is that there's a couple different dimensions of how that's manifesting, whether it's about LGBTQI patients being reluctant to disclose their gender identity or their sexual orientation to a healthcare professional because they have oftentimes a very legitimate and most of the time legitimate, honestly, or out of fear of discrimination, unequal care, and other negative patient-practitioner encounters. And really, that fear is not unjustified given historical context. If we're talking about how healthcare professionals have pathologized their identities, and also just in the sense of reinforcing certain societal and cultural fears about LGBTQIA plus patients, but within the guise of this medical objectivity. And then that still happens even today. As we can see, there are still about a lot of poor health outcomes when it comes to the LGBTQI plus communities. And what they actually have been finding is that a lot of these poor health outcomes are in some way or to some extent shaped and linked to experiences of stigma and discrimination that they face in society. And we'll kind of go into that, but oftentimes that particular area is informed by what is known as the minority stress model, which actually not only encompasses LGBTQIA plus experiences, but also experiences of race, class, socioeconomic level, if we're talking about that, location, if we're talking versus metropolitan area versus rural locations, all those type of stigmatic and discriminatory experiences can actually influence our state of health outcomes. And then also another fact I actually just recently found out is that the ICD codes, which are often used by evidence-based practitioners in their professional lives, continue to actually pathologize transgender identities, even though there have been some changes to ICD codes. But even the most recent ICD codes, or their most recent edition, still continue to do so in different ways, particularly with how they label transgender identities. And then ultimately, my last point here is that educational programs have been shown within the evidence to be effective at increasing student and even experienced healthcare providers and their knowledge about LGBTQI plus communities and their healthcare. So so there's a bunch of different dimensions to this, and this only covers just a select few, just to kind of provide a context as to why this even matters. Why are we even discussing this even now in this workshop? But yeah, and with that, I actually wanted to also lead into the dimensions of gender and sexual diversities, which I think, again, as I was kind of talking to a little bit before, is that we all come with different perspectives and different ideas of what those different concepts even mean and what they represent. So one of the fun things I've ever found to ever describe gender and sexuality and sex has been this graphic, the Genderbread Person. And there's been multiple variations of this, but this is the most current one. And really, it's a great way of briefly kind of covering the different types of dimensions of gender and sexuality and sex without having to reduce it down in terms of trying to make it so simplified that it loses just the very diversity of what we're talking about here. Particularly, as you can see, there's about identity, attraction, expression, and sex. So identity in this case is referring to how you experience and how you define your gender, which is primarily based on how much you align or don't align with what you understand the options for gender to be. So this is really referring to more your inherent understanding of what your gender is and who you are, essentially. And again, the way I was talking about how it aligns or doesn't align with the options of gender is really referring to that social aspect, especially when we talk about binary framework of male or female. But as we're coming to better understand is that those two options are not the only options. And really, even those two options have different types of context, different types of meanings behind them beyond what we readily assume. They're not necessarily the most stable type of concepts. And then with expression, that's really referring to how you present your gender, mainly through your actions. It could be your clothing, it could be your demeanor, your mannerisms, And really this is, again, stressing more the social dimension of your gender, as your presentation is often informs, or it often, your presentation often informs and is often informed by social expectations around you in terms of where you live. And then with sex, that's probably referring to what we usually refer to, like, or the stereotypical version of what we think of gender and sex. Oftentimes, some people will treat them as interchangeable, but sex is often referring to the physical characteristics that you're born with or that you develop. Oftentimes we think of sex in terms of sex characteristics. That could be like chromosomes, genitalia, reproductive organs, your voice, your body hair. But it also not only refers to your anatomical or your physiological makeup, but it also refers to your sex that you were assigned at birth. And then lastly, with attraction here, this refers to how you feel drawn or not drawn to other people when it comes to sexually, romantically, and or other ways. It doesn't even have to be necessarily sexual or romantic. And then oftentimes your attraction is often characterized in terms of gender. And again, this is kind of connecting how sexuality relates back to gender, but they're not necessarily the same thing. And oftentimes, even within how your attraction is based largely on gender, you know, that it kind of depends, honestly. And we'll kind of get into that. But another really cool thing about it is that, about this particular graphic, is that it not only shows the different dimensions, but how each dimension is a continuum. It's not necessarily, are you a woman or a man? It's like, to what extent are you to either one? And that's why it even has like the cancel sign. You could be not at all in the sense of gender identity when it comes to manness, but you might be more of womanness, or it could even be a mixture of, both, or it could even be none of them at all. And the same goes with gender expression. It could be anatomical sex, and even, again, attraction. So really all of these are not necessarily the same thing. So like identity is not necessarily equivalent to expression, and it's not the equivalent to sex, and how gender is not the equivalent to sexual orientation. They all have their own different components, but they all intersect and work together to composite who we are. And really the other reason why I kind of address this, so you might be already familiar with most of these dimensions already, depending, your own education, your own experience, and your own exposure. But the other reason I kind of address this, especially within the context of this workshop, is to really stress how we really should be thinking about how we're measuring these dimensions of gender and sexual diversity within our studies, within our research. Because oftentimes, we have like either we're measuring for just the behavior component in terms of like, do you do this, or, what are your relationships like, or, stuff like that. But those are only certain aspects and not necessarily encompassing all these other dimensions. So that's something to really think about, especially not only in terms of conducting your own research, but also evaluating research when you're actually doing a literature search, and seeing if how exactly were they measuring for all these different types of dimensions when it came to gender and to sexuality. So really the reason why, I wanted to address, the genderbread person, mainly just so we're all kind of on the same page in terms of the vast diversity. And again, even that particular graphic that we just seen doesn't necessarily encompass everything. It's really a quick way of trying to cover a bunch of the different dimensions in a way that could be readily understood, or at least more quickly relatable to us. But honestly, with our understanding of how gender and how sexuality work and how they function and how they manifest, it's always changing. That's one of the cool things about it. And in particular, a very recent theory that it's kind of emerged to kind of address these particular, differences, and not only just differences, but also similarities between genders and between sexualities, is queer theory. But, queer theory emerged in the 1990s. So again, it's a very recent theory that's actually come up, but honestly, it was also informed by decades previous by a number of like philosophers, social thinkers, feminists, who were already trying to ask the questions of, what is gender, what is sexuality, and more importantly, is our current understanding of gender and sexuality necessarily the best conceptualization of it, the best approach. And in particular, as the first point addresses, it is that queer theory, one of the main premises to it is that it addresses and decenters heteronormativity. So as a word, it seems kind of complicated, but honestly, it's referring to heteronormativity is referring to how there is a worldview that we have regarding gender and particularly sexuality that predisposes or basically makes the assertion that heterosexuality, basically straightness, is not only the preferred sexual orientation, it's also the default, the normal option. And essentially it frames anything other than that, particularly if we're going to talk about, gay and lesbian relationships as being abnormal or as being a variation that's not necessarily, again, normal, or in the sense of being preferred, and in a lot of ways wrong in that sense. And basically it's also re-solidified also gender identity, because essentially it created or heteronormativity essentially asserts that binary gender, particularly man or woman, is the preferred or default options that you have available to you. And one of the things that it also contests is that this essentialist truth, I put it in quotes because it's, again, very questionable as a truth, but it was really for years, for at least 200 years during since the Victorian era, the truth, or the scientific truth in some ways, that gender and sexuality are exclusively biological. And that they essentially are determined by our biological, our anatomical, and our physiological bodies. And therefore, those lived experiences are the only legitimate ones. Anything that goes beyond that binary or beyond heterosexuality or straightness is fundamentally abnormal, it's wrong or incorrect. And so essentially, again, it's challenging that binary framing of gender and sexuality, and really trying to move away from the idea that, it has to be either or. And I also added that it tries to move away from oppositional, in the sense of like it has to be man versus woman. That's often what's happening here too, or heterosexuality versus, gay, lesbian, bisexuality, and so on, and even asexuality, the absence of like any sexual attraction. And essentially what it's wanting to do is that a lot of times our gender and our sexuality are much more complicated than just being an either or situation, or only being one particular label or identity. For example, actually, for straight men in particular, there's many that will describe themselves and fully label and fully, embody the identity of being heterosexual, but they may have sex with men or with other men. And they might have sex with other women, but they do have sexual attractions to and relationships with other men, but they describe themselves and fully embody being heterosexual. That is their identity. So really, it's really suggesting how even heterosexuality and straightness are not necessarily fixed or static or unchanging. they can be definitely a lot more flexible than we really think of them. And that goes with any of these other identities that we're talking about. And that's another thing, is that it's actually queer theory helps us to reposition heterosexuality in the conversation, because a lot of times when we're talking about LGBTQIA plus communities, it's often termed as like they are the diversity. But the problem with that, with the idea that they represent diversity, is that heterosexuality is left off the table. And that it implies again, or reinforces the idea that that is the normal, that is the default. So that, you know, it's a really, and honestly, that even goes with in regards to racial diversity. If we think about racial diversity, oftentimes we're talking about people of color or BIPOC, but we don't include the discussion of the positionality of whiteness, right? And that goes into that as well. But yeah, and actually speaking of like racial diversity or class diversity and language diversity, any of those other types of diversities that we're talking about, one of the things that queer theory actually has been working towards is that even though it's specifically about queerness or LGBTQIA+, what it has been doing actually is applying a intersectionality lens. And intersectionality I do address in a different workshop actually. But as a short thing, is that intersectionality basically states that a lot of our different identities when it comes to race, when it comes to gender, sexuality, language, again, where you live, anything like that, they don't operate in vacuums. They don't just like, that's just one part of me and the other part of me, and they don't talk to each other. They all intersect and interlock in different ways. They complicate each other to give us either privileges or disadvantages and barriers and other types of ways of informing how our life experience is going to be. So queer theory has really been, trying to connect those dots, and it's really been leading the way in terms of intersectionality and really complicating that it's not just an LGBTQIA issue. It's, it's an issue in regards to race or language or anything like that. When we're talking about all these other types of social inequities. Right there. Oh, nice. Okay. And I see in the comments, if anyone has Disney Plus, the documentary Gender Revolution, A Journey with Katie Couric, also discusses the genderbread person. Oh, that's awesome. And it's a pretty cool documentary, and someone I believe has commented having seen it and having discussions about it. That's awesome. I haven't actually seen that personally, so I might have to check it out. It's on Disney Plus. I'll have to check. So yeah, no, I mean, that, and we're having a lot of different types of exposures to it and a lot of different discussions. And yeah, and I think it's definitely something to address within the medical and health sciences in particular. And again, this is kind of the reason for the workshop in the first place, is because oftentimes with heteronormativity, it's often described as a belief. So for me, that kind of becomes problematic, because sometimes we may label it as being an individual problem, that it's just, a few people who believe it, or it's just more of a personal thing that we all have to address. But one of the things about queer theory is that it's not only talking about individual people who might be espousing or supporting or promoting heteronormativity. It's also the institutions that we're living in as well. And honestly, those could be education. So it could even be, university institutions, and how we're having to address, curricular content. Is it really addressing different perspectives that would support queerness and LGBTQIA, or is it otherwise kind of leaving it out? Or it could be even, again, for more relevant probably to you as well, is, healthcare and the medical sciences and the medical fields. As I kind of alluded to before and kind of mentioned, is that medical professionals and healthcare professionals are not exactly immune to heteronormativity in their own clinical practices. And this also includes research as well. As we'll kind of talk about, is that clinicians, researchers have certain privileges where they can basically reproduce the pathology of LGBTQIA+, and that's been something that's been having to be addressed for several years. And it's something that we're constantly having to work with. And that's, again, why there is a very legitimate fear of discrimination, of unequal care, because it's either because of inexperience or lack of knowledge, or just not necessarily listening to that knowledge and not really, incorporating that into your practice. So, but yeah, it's a really complicated theoretical framework, and actually it didn't even start in the medical fields, but it actually started more in philosophy and actually particularly language, especially when we were actually how we had to have a better understanding of what we meant by queer in particular, which if you're of an older generation in particular, or even now, like even current generations, they might interpret queer as being something derogatory. And honestly, queer theory and among the social movements around it have been seeking to reclaim it, in terms of what queer means, because queer allows for a lot of flexibility in what it means for different people. In terms of like being queer questioning, whether you're still trying to figure out your identity. And it also reflects that not every identity is necessarily a fixed one. But one of the things too to keep aware of, especially if you're not part of the LGBTQIA, from what I've understood, is that even though like queer theory kind of challenges that these are not like fixed or solid or unchanging type of identities, that doesn't necessarily mean they're not meaningful to members of these communities, that they do want to uphold to their identity as being a lesbian. And because a lot of times if people try to say, well, because it can change so much and it essentially is meaningless, particularly with the argument like being a lesbian is like a fad or a trend, kind of that kind of stuff, where it's just a meaningless thing where you could just act out being lesbian and then switch back to being heterosexual. And really when we all really think about our own sexuality, our own gender, we know that's not necessarily the case, where we can just switch from role to role kind of thing. It's really a meeting of what you inherently know about yourself, as well as how society is also influencing your own perceptions and your own experiences as well. So it's really kind of a meeting of forces in that sense. So yeah, like in particular, when they try to talk about like, is it just purely biological or is it purely nurture kind of thing, like nature nurture thing? Really, the idea of it being opposing, and again, the oppositional is kind of a false option, like in the sense like that's the only option. That's not the only option. It can be an and both instead of an either or. So. But yeah, again, it's a really huge theory to kind of go into, and honestly it's actually only just started to kind of be broaching into the medical sciences in particular. Really, when I was looking into the scholarly literature, there's not a whole lot of medical literature that actually addresses queer theory by name, but there has been a lot of work that maybe not labeled as queer theory, but they're still doing that type of work as well in terms of addressing these central premises and principles. So I do see from Sarah that it's interesting. Yeah, I totally agree. I love reading this type of work. If you ever do need recommendations on who to read to kind of get more in depth about what queer theory is, I can totally provide you a bibliography to go for. But yeah, it's been one of my interests, and honestly, it's been one of the ways I've been wanting to drive my own workshops here to really contextualize in the voices and the experiences that are not necessarily my own. Like I said earlier, I'm a white, straight, cisgender male, so I don't necessarily have the lived experiences here to go by. So I really go by the voices and the experiences that are told through queer theory and other like experiential knowledge that is being shared. So that's how I kind of try to contextualize and how I try to promote that as well. But yeah, I'll move on with that. So one of the things I did want to talk about briefly in terms of how you can actually implement a lot of this stuff that we've been talking about in terms of queer theory and the genderbread person, and actually putting into some type of practice. So really one of the things probably for students like yourself or faculty even is phrasing research questions that are inclusive. And in particular, I kind of worded this more towards LGBTQIA+, but you honestly want to do a little bit more work when it comes to race or socioeconomic level, anything like that, or housing instability, food insecurity, anything like that, whatever is relevant to what your patient or your community that you're trying to address. And really, that's the kind of the first point I make is like, does your question actually reflect the identities and the experiences of your patient or community? Really just speaking from like working with like beginning students in particular, oftentimes when they're doing PICO analysis, trying to develop from keywords for their population, the intervention, the comparisons if there are any, and then the outcomes, when they do the population patient sector, they really kind of focus more on the health conditions being addressed. And while that's not necessarily wrong, like you're probably going to come up with a lot of good evidence doing that, sometimes they miss the nuance of who their patient actually is in terms of their background, their cultural frame of mind, and also, yeah, again, like gender identity, sexual diversity, anything like that. And that might be missed out. And we'll kind of talk about a little bit more in terms of what is actually out there when it comes to gender and sexual diversity, especially when in the context of medical literature and just the scholarly literature in general. But, that's something to keep in mind, is that maybe one of your key words to really identify literature that is more appropriate or more relevant to your specific patient or your community is to look at their identities and use those as keywords. And then, yeah, what demographic information are you collecting from your patient or from your research participants? And really, this kind of goes into what I was talking about earlier with the Genderbread Person, because what I wanted to raise is when you're doing a research study, obviously you're going to collect some demographic data about your participants to kind of fill out what exactly the population you are looking at. But it's up to you, depending on how your survey's framed, how you're defining certain concepts, and particularly the concept of gender and sex and sexuality are definitely part of those. And sometimes those questions kind of get left out entirely, which kind of makes those issues invisible in a lot of ways. Or they are only accomplishing one aspect of gender identity or one aspect of sexual identity. Particularly like say like, there's, the question that you kind of get most standard survey where it's like, what is your gender? And it says like male, female, and sometimes it provides the option for other and sometimes it doesn't. Again, that's kind of fixing within a binary. And one of the issues that actually comes up is, especially with trans, because there, a lot of the trans communities living within that binary, they identify themselves as a man or a woman. And for them, for a lot of them, they don't necessarily put themselves as other in that option. They put themselves in the identity that is most appropriate to them. So that would be a man or a woman. And the problem is, as a researcher, you wouldn't know if they were trans or not, because the option wasn't there. And so it made more sense for them to put themselves as man or woman, depending on their gender identity. Other probably be more appropriate for people who just don't prescribe to the binary. So it'd probably be more non-binary people that you'd be getting from the other option. So that's something to consider. And that actually is something I wanted to talk about with your patients even, because a lot of times you have probably a patient intake form that asks similar questions because you're trying to get more data about your patients so you can readily treat them. It helps to inform your practice, right? And a lot of times that same type of issue can pop up. So really it's just a matter of being able to collect that data that would be inclusive and still relevant to not only your patient, but to yourself in terms of how it would inform your practice. Would it make a difference knowing that they were trans or were they cis? Stuff like that. Or even like for sexual orientation, that can definitely be the same thing depending on the context of who you're working with and for what reasons. So yeah, and like I said at the last point, PICO is a really useful strategy when it comes to developing appropriate keywords, and particularly I wanted to stress it in the context of gender identity and sexual diversity. You know, I don't think we really think about that, but that's one of the things I wanted to contextualize and really make a standout point here is there's another reason to have PICO other than just breaking down a question. It helps to really single out or make a more nuanced search of the evidence. So I have a couple of terminology resources which I can link after the session. I'm more than happy to do so, that I thought were pretty useful in terms of developing your own vocabulary for LGBTQIA plus communities, and not only appropriate language, but also inappropriate or even offensive language that you should probably avoid. So, but yeah, I'd be happy to share those as well. Let's see. So yeah, just to kind of move on to is that with actually, you know, developing your inquiry, or in my, like when I'm saying inquiry, I'm really meaning the literature search in this case. Really, there's a couple things that we really need to ask ourselves as we're doing the search. And particularly when it comes to LGBTQI plus communities, as well as other communities, or even you know, communities within the LGBTQI plus communities, because we'll talk about that. You know, the fact that you know, when it comes to the question how much research is available, the answer really is that it's been growing, but it's not a lot. Like in the respect of really focusing on LGBTQIA plus health issues and topics. You know, again, it's been growing a bit, but actually within the last like 60 years, from my last look at the data, was that really like up to 2% of the of all total literature, especially if we're talking about like PubMed, represents or specifically addresses LGBTQIA plus communities. And more importantly, even within that, it tends to be where it's kind of generalizing all LGBTQIA plus communities, like in the sense of like a study would just kind of generalize to all, but not necessarily focus on the distinct and very unique health outcomes that happen within those communities, particularly within gay or lesbian communities. There's completely different issues for those groups. And there's some overlaps, you know, definitely, but you know, the same could be said for trans as well. And so a lot of it tends to be very generalized and not necessarily nuanced to really to look at, like specifically trans men or two-spirit Native American communities, or intersexed would be another, or anything like that. So yeah, and really that kind of just identifies, especially for yourself as a researcher, if you're actually interested in doing research, those would be areas that you could explore, because there isn't a whole lot in there. So you could be helping to fill those gaps. Another important thing to consider too is how do databases like PubMed that we readily use all the time, especially as students and even as practitioners, how do they organize all that information, and how do they categorize it? What kind of language are they using? And I raise this point because in the right-hand side of this presentation here that you can see, I have the language of PubMed, which is known as MESH. It's an acronym that stands for medical subject headings. Basically, the MESH is composed of a vocabulary of words and phrases even that the developers behind PubMed have assigned to the articles in particular. So each article has a list of different appropriate MESH terms, depending on the topic of the article. So if you're talking about an article that is talking about heart attacks, for example, the appropriate MESH term for that, and the one that's going to be labeled on those articles, is going to be myocardial infarction. So that would be one thing. Or even with, like, if it's an article talking about physical therapeutic interventions, and that's the main focus of the article, it'll probably have the MESH term physical therapy modalities. And then there's a completely different one that is physical therapy specialties. And that MESH term is referring to any articles that talk about the profession of physical therapy. So any articles that have that MESH term versus the modalities one. So yeah, so and again, These are they're fairly static type of mesh terms. It takes a long time for a new mesh term to be developed and to be made available and then assigned to articles. They tend to be very static. They tend to stay the same for a long time. And in particular, you can see that I have a bunch of terms that are relating to LGBTQIA, and these are actual mesh terms that PubMed uses and the year that they were introduced. So you can see that early on it was about like transsexualism, which was, from what I found, the most early mesh term that they developed. And again, that term hasn't aged very well. It's, kind of been abandoned pretty much. And even PubMed has tended not to use it for more recent articles and in place of others that we'll talk about, as you can see here. But transsexualism was the most common mesh term, and so therefore a lot of the articles that you'll see stretching all the way to 1968 have that term. So you would have to use that term in PubMed search to actually find those articles. The same could be for bisexuality, homosexuality, female, homosexuality, male, and honestly, even homosexuality has kind of, aged out. It's no longer really a appropriate term to use in respect to like gay or lesbian, but it's still used. Even with 1995, it's still used to this day. And only recently have we actually come across the terms transgender, which just got introduced in 2016, and then intersex persons got introduced last year. And then even sexual gender minorities, which has become kind of the umbrella term that they've used for any of these communities, was only introduced in 2018. And the thing to really consider here when you're doing a literature search is that the year it was introduced kind of determines how useful that term will be for the coverage that you're going to get, the coverage of results. So as an example, say like I wanted to do a search for intersex persons, and I specifically wanted to use the mesh term here for any articles that were labeled with that particular mesh term. I would only find articles up to 2020. The reason being is that they don't have a system or procedure where they retroactively apply it to any articles before then. It likely had one of these other terms instead, in some fashion or form. Same thing for sexual and gender minorities. If you use that term, you probably only come up with results that only speak to 2018, even though there's probably other articles before then that were not assigned that mesh term, but still talk about it. So yeah, and again, it's just kind of speaking about even how the language of the databases, the internet search engines that we're using can be very biased, not only in terms of time, in terms of stretch of time, but also in terms of, some of these just didn't age very well. And again, I just wanted to, again, reinforce the point is, are the keywords that you're using reflecting your patient or community in the literature search? So one of the things I want to stress here is that you don't necessarily have to depend on these mesh terms to do your search. What I recommend doing is actually a mix of mesh terms as well as your own keywords, because they might have identities that are more nuanced and that are not recognized as a mesh term. They might be just more of a natural language term that we use. An example would be Latinx, which has become a more recent emergence of trying to accommodate not only the identity of Latino, but also to include LGBTQI communities that are Latino. And a whole host of other types of versions can be found as well. But yeah, I mean, that's something to take in regard is that Latinx is not necessarily a term, or it is a term that you want to consider if it's more appropriate for your patient, because you might come across articles that are speaking to Latinx populations. They just weren't assigned one that would reflect that, like in terms of any of these mesh terms. So using a mix of them is totally fine. And I actually encourage it usually. Yeah, and then the last thing I say is, applying an intersectional approach to your search. What I'm really mean is yeah, again, if you have a patient that is LGBTQ, but is also Latino, could be Black or African American, white even, those are important keywords to maybe consider in your search, or at least to look into the actual studies that you're reading to inform your practice or your literature review or whatever you need the research for. And again, that's kind of an important evaluation of the evidence type of technique that you should consider. But yeah, one of the last points I was going to make too is diversifying your research practices. And what I really mean here is, and this really comes in not only the conducting of your research, but also the evaluation of research, especially when you're doing like evidence-based practice. So I really like, even though I keep talking about research a lot, really, in the spirit and the movement of evidence-based practice, you do need to have these skills as well, because you need to look at the literature in a way that can identify these type of issues. That way you're not treating a patient and trying to use this generalized finding that you found, but it's not actually speaking to your particular population or your patient and their unique needs and expectations and experiences. But yeah, so when I say about diversifying your research practices, one of the main principles, and it may seem kind of interesting and it does require a little bit of work, is involving your patients and the communities in the literature search or in the research process overall. This is something that you kind of really need to address when it comes to any type of vulnerable or marginalized population. But LGBTQ, that's especially relevant. Because oftentimes they can give you a little bit more insight into, what exactly is relevant to them, whether it's maybe developing keywords or finding literature that best fits their own needs, their expectations, their experiences, and even with the research process too, because one of the really things that we really need to work on as researchers is being able to be more representative and more empowering in the research that we produce. Because like I said, with the medical sciences in particular, it has had a history and even a current reality where it tends to pathologize a lot of these identities as being associated with disease or a wrongness of body in some way, when we're talking like particularly when it came like with the HIV AIDS epidemic, or it can even be about gender dysphoria, anything like that. It tends to have a very pathological approach to those issues rather than being more inclusive and actually including the experiential knowledge that can be offered by these communities. And then, my other points here are to incorporate queer theory and intersectionality in your critical appraisal of the evidence. So as you're probably learning on your own, it's like having to apply critical appraisal tools when it comes to like GRADE or Joanne Briggs checklist or Prisma. But a lot of those tools don't actually involve questions about the population in particular. There's some questions, but really they don't specifically talk about the diverse representation of the samples or the populations being addressed in these studies. So really, if you look at the sampling methods and look at who they actually, talked to or, collected evidence from or collected data from, and really try to evaluate it with in mind queer theory and intersectionality, that could really enhance your own critical appraisal of the evidence and seeing if it actually is appropriate. Because one of the things about research, especially as I was kind of alluding to, is that a very small percentage actually reflects the health and the experiences of LGBTQIA+. And actually overall, most research actually reflects a very homogeneous population. And by homogeneous, I'm really talking about white male, cisgender male in particular populations. So that's been the primary focus of most medical research and just research in general. So it's something that we really have to address. And then, and then also assessing therapeutic interventions and outcomes in the context of gender and sexual equity. Again, kind of relating back to the critical appraisal of evidence, is making sure, are these therapeutic approaches that you're looking at appropriate, relevant? Are they, can they actually be of benefit to these communities that are often kind of left out in the conversation? But again, I want to thank you all for joining in this and, hearing me speak. on these issues and these topics and these resources, and how we can really better ourselves to help support these communities, especially in terms of patient care and health outcomes. It's a super important topic. And honestly, this is really just a touching stone. This is really a starting point in your journey towards that, in terms of addressing that. So there's plenty more to learn out there, and I'm always happy. If you ever want to contact me directly, feel free. I have plenty of more to talk about when it comes to these topics and other topics when it comes to anti-racism, intersectionality, and so on. So these are definitely within my wheelhouse, so I'm always happy to do so. Or even just like a consultation if you actually have a project yourself that you're kind of working on that kind of addresses any of these issues. I can definitely help provide some guidance at least. So, but yeah, thank you so much.